Hello, everybody. My name is Dimitrios Tapsas, and I'm a pediatric gastroenterologist working both in Sweden and Greece. My presentation today will deal with the prevention and treatment of cow milk's allergy, and we will also discuss the prevention of other food allergies. I will start my presentation with some epidemiological data. This type of allergy is one of a worldwide concern. As you all probably know, it is estimated that in 2025, not so far away from today, about 50% of all the EU citizens will suffer from a type of allergy. More specifically, it is known that about 17 million people suffer worldwide from a food allergy, and among them, 3 million are children. As you can see on this slide, it's estimated that 1 out of every 20 children has a diagnosis of one or more food allergies in Europe. On this slide, it is shown that since the 90s, there has been a fourfold increase in food allergies among the pediatric population in the United States of America. There are many factors that are associated with the increased prevalence of food allergy, such as the late introduction of allergenic foods, the change of our eating habits during the last decades, for example, the industrial manufacturing of food, the dysfunction also of the skin barrier. An example here is the situation of eczema, or even our new hygiene habits were increased in a good way during the last years, but also the alternation of the gut flora. Data from the Europreval cohort study reveal that the incidence of food allergy, different food allergies, as you can see here, concerning peanut, for example, wheat, egg, cow milks, during the last decades have increased significantly in Europe. And we are talking about both IG mediated and non-IG mediated food allergies. The incidence of a cow milk allergy varies from country to country, as you can see on this slide. There are countries that estimate the cow milk allergy among their population with an incidence less than 0.3. Such countries are Lithuania, Germany, and Greece, but other countries have higher incidences of cow milk allergy, reaching up to 1% in the Netherlands. The major allergens of a cow's milk are the 4-casein fraction proteins and 2-whey proteins. There are described two, as you all know, types of cow milk protein allergy, the IG-mediated and the non-IG-mediated. In general, the prognosis is better for the non-IG mediated allergies. As we all know, at the age of 12 months, 100% of children will be able to tolerate cow milk protein, while this occurs only in 57% among children with IG-mediated allergy. Food allergy gives symptoms from the gastrointestinal tract, the skin, even the respiratory system. Some examples are dysphagia, vomiting, diarrhea, constipation, hematochezia, poor weight growth, urticaria, eczema, wheezing. And in these cases, we have, in cases, of IG-mediated reactions, all these symptoms can occur within minutes to 2 hours. And as you can see, the symptoms that are highlighted in blue are the most common ones for the IG-mediated reactions, while the non-IG mediated reactions can also give such symptoms, but in the majority of the cases, the symptoms occur from the digestive tract and or the skin, and the reactions take place later, not as quick as in the cases of the IG mediated food allergies. As it is well known that a case of a non-IG mediated reaction is the food protein-induced enterocolitis syndrome, otherwise FPIES, as you all know it. And it can be caused by different food allergens, and one of them is also the cow's milk. The prevalence of FPIES is estimated around 0.34, but many scientists claim that this is an underestimation of the prevalence of this situation. They assume that the prevalence is higher, but in many cases, FPIES is underdiagnosed. Various organizations approach the diagnosis of cow milk's protein allergy differently. I will present you now how the European Society of Pediatric Gastroenterology, Hepatology and Nutrition, otherwise ESPGHAN, is approaching the diagnosis of cow milk's protein allergy. The algorithm they suggest is the following. We need first to obtain the history of the child and then perform, of course, a physical examination. If by the history we get the information that the reaction was immediate, in that case, we need to eliminate cow milk's protein and test the patient for specific IG antibodies. If the antibodies are positive, the patient will exclude the cow's milk protein from their diet. If the antibodies are negative, we have to challenge the patients with cow milk protein, and if the symptoms occur, in that case, the patient will receive a diet without cow milk protein allergy, but in case that the symptoms will not occur, in that case, the diagnosis should be something else and not cow milk's protein allergy. If the reaction is late, in that case, we exclude cow milk's protein from the diet of the child. If the symptoms persist, we look for another diagnosis. If the symptoms resolve, we challenge the patient with cow milk's protein, and if in that case the symptoms reoccur, we have to put the patient on therapeutic elimination of cow milk's protein, and if the symptoms do not occur, in that case we have to look again for another diagnosis. The cow milk's protein allergy in that case is not relevant. The IG antibodies that we use in order to elucidate cases of cow milk's protein allergy have a median sensitivity around 87%, and their specificity is about 38%. It's a median specificity. On the other side, the skin prick test that we use sometimes in order to diagnose the situation has a sensitivity around of 88% and a specificity of 68%. Skin patch test is not recommended for the diagnosis of cow milk's protein allergy. For the non-IgE mediated reaction, elimination and provocation with cow milk's protein allergy is the most reliable diagnostic tool that we have for such cases. The European Academy of Allergy and Immunology suggests as a treatment for non-breastfed infants extensively hydrolyzed cow milk formulas or amino-based formulas for children suffering from severe symptoms. It's difficult maybe to read clearly the recommendation because they're written with small letters, but I hope I get the message to you clearly. The extensively hydrolyzed cow milk formulas contain oligopeptides with a molecular weight less than 3,000 Daltons. The amino-based formulas can be first-line treatment in cases of cow milk's protein allergy, as I mentioned before, but they have a high cost and they taste worse for the child in comparison to the extensively hydrolyzed formulas. Soy formulas, the European Academy suggest can be used after the 6 months of age, not before. For breastfed infants, mothers should be advised to continue breastfeeding while avoiding consumption of dairy products. Also, the Academy suggests that probiotic supplement is not recommended for the management of cow milk protein allergy. In cases of anaphylactic reaction, the first line treatment will be the amino-based formulas, not the extensively hydrolyzed formulas. In all other cases, we can use the extensively hydrolyzed formulas. Excuse me. The following products are not recommended for the management of cow milk protein allergy. First of all, I have to mention the partially hydrolyzed formulas that cannot be used. As I mentioned before, we shall not use soy formula during the first 6 months of life, and it shall not be given to children because they are those formulas insufficient nutritionally. Milk from other mammalians like sheep, buffalo, horse, and goat cannot be part of the management of cow milk protein allergy. And this is because of the risk of allergenic cross-reactivity and because also their insufficient nutritional value. Unmodified soil or milk products shall not be used on children with cow milk protein allergy because they are also poor in energy and protein. And the same thing applies for milk beverages that are based on almond, coconut, hazelnut, oat, potato, rice, and soya. The diet should be reassessed every 6 to 12 months to determine if our patient has developed tolerance to cow milk protein allergy. And the elimination diet is the only known treatment for cow milk protein allergy. In case of an anaphylactic reaction, which occurs not so often, we should administer to our patients adrenaline, antihistamine, and systemic glucocorticosteroids immediately. In the world of allergies, oral, sublingual, and epicutaneous immunotherapy can be used. More specifically, in cases of a persistent cow milk allergy, oral immunotherapy can be considered from around 4 to 5 years of age. The therapy should be, though, given in highly specialized clinical center, suggests the European Academy of Allergy and Immunology. Of course, this does not apply exactly for the United States of America, as the FDA until 2018 hasn't approved any immunotherapies for food allergies. One limitation for the oral immunotherapy is the risk of adverse effects, although they are mostly mild and self-limiting. And now some take-home messages so far. As I've mentioned before, food allergy is a global health issue with increasing prevalence. The diagnosis of food allergy in our case because we've discussed mostly about cow milk protein allergy, will be based on history, the diagnostic elimination of cow milk protein, and skin prick test and specific Ig antibodies. The only known treatment is the avoidance of the offending allergen. In this case, it is the cow milk protein, and oral immunotherapy is not yet recommended as a routine practice. Now, some data on the prevention of cow milk allergy and other food allergies. We will discuss the following issues in terms of allergy prevention: the exclusive breastfeeding, the use of dietary products with reduced allergenicity, the early versus delayed introduction of complementary foods, and of course, the use of pro and prebiotics in the food of children or their mothers in some cases. Exclusively breastfeeding might help to prevent allergic disease by decreasing exposure to exogenous antigens, protecting against infections, promoting gastrointestinal mucosal maturation and development of a gut microbiota, and also conferring immunomodulatory and anti-inflammatory benefits. Overall, the evidence on the effect of breastfeeding is inconsistent, showing in some cases protective effect, in some other cases no effect, or even predisposing effect. That doesn't mean that breastfeeding does not have a significant effect on the prevention of the allergies, although those inconsistencies reflect, in the majority of the cases, a variety of methodological problems associated with investigation this subject. ESPGHAN, the European Society of Pediatric Gastroenterology, Hepatology and Nutrition, and even the American Academy of Pediatrics recommend exclusive breastfeeding for the 4 to 6 months of life. Now, some words on the use of dietary products with reduced allergenicity. On this slide, you see highlighted some controversial material from different meta-analyses. 3 out of these 4 meta-analyses highlighted in green suggest that hydrolyzed formulas, even partly hydrolyzed milk formulas, compared to regular formulas which are not hydrolyzed, are effective in prevention of allergy, particularly in children with high risk for allergy. Although the last meta-analysis highlighted in red by Boyle and collaborators couldn't confirm the previous conclusion. The American, the Canadian, the European Societies of Allergy and Immunology recommend hydrolyzed formula for high-risk children as a prevention tool of a cow milk protein allergy. Although the Australian Society of Allergology and Immunology does not fully confirm this above previously mentioned conclusion, especially for the part of the partially hydrolyzed formulas. Some comments now on the early versus delayed introduction of complementary food and potentially allergenic foods. All the previously mentioned societies agreed that there is no convincing scientific evidence that avoidance or delayed introduction of potentially allergenic foods beyond the age of 4 to 6 months reduces allergies. This is a clear message from all those societies. This is based on different studies, as the Koala study, the LISA study, Gini studies, who were all prospective birth cohort studies. Here you see some RCTs on the subject investigating different types of food, suggesting the exact same message as I mentioned before, that the delayed introduction or of potentially allergenic foods beyond the age of 4 to 6 months does not reduce the allergies. Now, some data on the peanut allergy. The LEAP study that you see here on this slide shows that introduction of peanuts in the diet of children with moderate or severe eczema between the age of 4 to 11 months, instead for completely avoiding the peanuts, until the age of 5 years, reduces the prevalence of peanut allergy in about 81%. This is significant reduction. The current recommendations about the peanut allergy are the following. This is published on the New England Journal of Medicine and includes recommendations from all the previously mentioned pediatric associations concerning allergy and immunology. And these recommendations suggest that the healthcare professionals should recommend introduction of peanut-containing products into the diets of high-risk infants early in their life, between 4 to 11 months of age, in countries where peanut allergy is prevalent. Otherwise, if this introduction is delayed, this can be associated with increased risk of peanut allergy in the future. As I mentioned before, the Australian Society of Allergy does not recommend partially hydrolyzed formulas for the prevention of cow milk protein allergy. They also suggest to start weaning at the age of 4 to 6 months of age and introduce peanut, boiled egg, and wheat before the age of 12 months of age. Yes, these were the recommendations, sorry, not the previous slide. The European recommendations until 2018 suggest that peanuts shall be introduced in the diet of children between 4 to 11 months of age. There is also no evidence that avoidance or delayed introduction of peanuts or allergenic foods beyond the 4 to 6 months of age reduces allergy. Now, studies show no benefit of probiotics in allergy prevention. Although there is low quality of evidence, the World Allergy Organization suggests probiotics in the following 3 cases in order to prevent eczema, not food allergies. And those 3 cases are the following: pregnant women at high risk for having an allergic child, women who breastfeed infants at high risk for developing allergy, and the third group are infants of high risk for developing an allergy. And these are conventional, as I mentioned before, conditional, recommendations with very low quality of evidence. About prebiotics, there are no recommendation for their use on pregnant women, breastfeeding mothers, exclusively breastfed infants, in order to prevent allergies in the future. On the contrary, non-exclusively breastfed children might benefit from prebiotics, although data supporting these recommendations are poor. And I'll give you some seconds to read those take-home messages that I would like to give you before ending the second part of my presentation concerning the prevention of cow milk protein allergy and other food allergies. Thank you for your attention, and now it's time for some questions. I'm available for those questions, so please shoot.